can respect. Perfect. So give me just 1 second to share my screen and we will go from there. Perfect. So let's see. There we go. And Paul, you just see the one slide, correct? Good. So welcome everyone. It is September. We're moving into fall, which is lovely, not nearly as hot as we were just talking about. And this is the September online version of the JVS Journal Club. Tonight, our host institution is the University of South Florida. And one of the unique things about the University of South Florida and the way they do this online journal club is they have their entire residency and their faculty gather and then have dinner, and then the journal club comes on and they participate in it that way. So we wanted to highlight that and show that this is something that could be used in a big aggregate setting to do a monthly journal club. And they've been gracious enough to host tonight. There are 2 articles we'll be discussing. Severity of stenosis in symptomatic patients undergoing carotid interventions might influence perioperative neurologic events. And then also the impact of emergency endovascular aneurysm repair protocol on a 30-day abdominal aortic rupture mortality. And we've been joined by their faculty from the University of South Florida, Dr. Desiree Picconi. She's an assistant professor and an associate program director for vascular surgery. She is paired with Dr. Aaron Ambrose, who's their first-year fellow. And then Dr. Christopher Latz, who's also an assistant professor in the Division of Vascular Surgery. And he will be co-presenting with actually, I think I have it backward, don't I, Desiree? I just realized that I have it flipped, but with Dr. Chethan Dargan, who's their integrated 5th-year resident. So we're very lucky to have our author guests. This is always a highlight for us, is to have some of the authors from the paper itself. Dr. Karen Rockman is joining us as the senior author from the carotid paper. And then Dr. Randy Moore and Melissa Jones are joining us for the aneurysm protocol paper. We have 2 special guests, which are our moderators, Dr. Luc Dubois, who is an associate professor at Western University, and then Dr. Naeem Nasiri, who is at Yale, an associate professor of surgery, and also the chief of vascular and endovascular surgery at the VA Connecticut. Just a few small housekeeping things. We ask that you please stay muted. We will prompt you to put your questions in the chat for discussion by Dr. Dubois and Dr. Nasiri. The event is being recorded for on-demand access, and then the October JVS Journal Club will be October 12th, and that's going to be 7 p.m. Eastern time. You will see it advertised on social media and on SVS Connect, and the host institutions for that are the University of Washington and the University of Utah. So with that, I'll stop sharing my screen and I will turn it over to Dr. Picconi.
All right, let me share. To presenter. Thank you so much for the opportunity to showcase USF. We're excited to be here, and it has been a tremendously popular decision to switch to this as our journal format. The discussion, I think, nationwide, plus having the authors there is really invaluable. So it has been a popular move. So tonight we're going to get started with severity of stenosis in symptomatic patients undergoing carotid interventions interventions might influence perioperative neurological events. So carotid artery stenosis remains an important cause of strokes. Over the past decade, the strokes remain a leading cause of mortality, although our improvement in perioperative care and stroke prevention has resulted in it falling from the 3rd leading cause of death now to the 5th leading cause of death. However, we still have approximately 800,000 strokes in the US annually, and that costs us approximately $45 billion in healthcare dollars. 80% of those strokes are ischemic, and of the ischemic strokes, about 20 to 40% are related to carotid artery disease, which makes this a potential intervenable source that's very important. Whenever we talk about symptomatic carotid disease, we always need to highlight NASCET trials, landmark randomized control trial that really brought us into our current recommendations for intervention in symptomatic disease with very strong evidence at that time. So in NASCET, there was a best medical therapy group versus a best medical therapy plus carotid endarterectomy, and when looked at the comparison, In the severe stenosis, or greater than 70% but not occluded group, there was such a strong outcome that they actually halted the trial early due to patient safety differences with that. And you can see that there was about a 26% risk of ipsilateral recurrent stroke versus a 9% at 2 years, and that continued to be borne out 5 years. They did continue enrolling for the moderate stenosis criteria, which did also show that there is a statistically significant difference, although not as strong as seen in the greater than 70% stenosis, but that difference that you see of 15 versus 6% seen at 2 years continued to be borne out at 5 years. Another important randomized control trial was the European carotid surgery trial. Of note, they used a different system of measuring. So in order to compare the two, they did remeasure all of the patients that were enrolled in order to be able to use NASIC criteria and have more of a head-to-head comparison. So using NASIC criteria for that trial is consistent with a greater than 60% stenosis, and they had a very similar result at 3 years compared to NASIC. So based off of this, symptomatic carotid artery with stenosis greater than 50% has been the standard of care intervention since that time. This table, also taken from Rutherford, is a great way of looking at it. You can see their combined outcome, the difference in, and then the risk reduction. So in greater than 70% at 2 years, you have a risk reduction of almost 17%, and that correlates operating on 6 patients to prevent 1 stroke. And in the moderate stenosis group, you see about 10% risk reduction at 10 years, which correlates to operating on approximately 15 patients to prevent 1 stroke. Both of these trials, NASIC and European, used stenosis as their criteria in order to group the patients. However, we know that some patients have severe stenosis and will never develop a stroke in their lifetime. And we know that some patients show up with a stroke and have only moderate stenosis. So there are other factors that are important, and that comes into plaque morphology. There are certain high-risk features that have been identified that weigh into a plaque being more likely to have an atheroembolic event and therefore a stroke. That includes a fibrous cap disruption or a very thin fibrous cap, if the surface is ulcerated or irregular, if there is a large necrotic lipid-rich core, or if there's intraplaque hemorrhage. While these factors are things that should be taken into consideration by the surgeon in determining who should undergo surgery and help delineate risk factors, there's no specific guideline related to these, and this is an area of active research and investigation. Finally, once you have determined that you do need to intervene, we have now 3 different ways to treat carotid artery stenosis. The gold standard is open carotid endarterectomy. There's also now TCAR with flow reversal as your distal embolic protection, and then balloon angioplasty with stenting, or transfemoral stenting using a filter for distal embolic protection prior to balloon angioplasty and stenting. While there are many different trials looking at the perioperative outcomes of different methods here and also comparing the different methods to each other, there's not many trials that look at these different methods in relation to the degree of stenosis for these. So in order to try to better answer that, we get to our paper today. So I'm going to turn over to Chafin. He is one of our graduating 05 residents. He's phenomenal, and he's looking for a job.
Thank you, Dr. Perconi. Good evening. My name is Chafin Dargan. I'm a PGY5 integrated vascular surgery resident at the University of South Florida, and thank you for the opportunity to present today. Tonight, I'll be presenting the paper, Severity of Stenosis in Symptomatic Patients Undergoing Carotid Interventions Might Influence Perioperative Neurologic Events, from the groups out of NYU, Boston University, and Columbia University. To date, severity of stenosis has been utilized as an indirect measurement for embolic risk and is the primary indicator for carotid revascularization procedures. Factors leading to a carotid lesion becoming clinically symptomatic are not fully understood, but include patient-related factors, plaque morphology, and baseline perfusion to the brain, including collateral pathways. Symptomatic patients are known to have higher rates of perioperative neurologic events compared to asymptomatic patients. However, it has not been well described how stenosis severity affects these rates within the symptomatic population. The authors therefore sought to answer this question and look at outcomes of carotid revascularization in symptomatic patients stratified by stenosis severity. The authors queried the SVS VQI database for all patients who underwent carotid endarterectomy, TCAR, and transfemoral stenting between the years 2003 and 2020 for symptomatic disease, which was defined as a neurologic event attributable to the ipsilateral cortex in the prior 180 days preceding revascularization, as well as ipsilateral ocular symptoms in the CEA cohort. Patient demographics, procedural characteristics, and clinical outcomes were analyzed and stratified by stenosis severity, utilizing two cohorts, severe and non-severe. The severe cohort was defined as greater than 70% stenosis, and the non-severe cohort included patients with less than 50 and 50 to 69% stenoses. Stenosis severity was estimated by duplex ultrasonography in the carotid endarterectomy group, while both duplex ultrasonography and CTA were utilized in the stent cohorts. The primary outcome analyzed was post-procedural neurologic events, which was defined as any neurologic event, including both stroke and TIA, seen prior to discharge, but after revascularization. These events were not limited to those of the ipsilateral cortical hemisphere, and also included those of the contralateral hemisphere, vertebrobasilar origin, as well as any neurologic symptom thought to be cerebrovascular in nature and resulting from the intervention. Secondary outcomes included postoperative mortality and MI, and the composite endpoints of stroke death and stroke death MI. Categorical variables were compared using chi-square or Fisher exact test, and continuous variables compared using the student t-test. Univariate analysis was performed to compare the endpoints between the two cohorts, and multivariate analysis was employed to assess the independent predictors for postoperative neurologic events. A total of 29,614 patients were included in the study, with 11,506 patients undergoing carotid endarterectomy, 5,296 undergoing TCAR, and 7,811 undergoing transfemoral stenting. Regarding demographics, patients with severe stenosis in the carotid endarterectomy group were younger and had a lower proportion of males, incidence of diabetes, hypertension, coronary artery disease, and prior histories of coronary revascularization, as well as lower rates of statin, P2Y12 inhibitor, and beta blocker usage. Patients in the severe group had higher rates of current tobacco abuse and COPD. Similarly, in the TCAR group, patients in the severe stenosis category were younger and had a lower proportion of males. They had higher rates of current tobacco abuse and P2Y12 inhibitor usage. In the transfemoral stenting group, patients with severe stenosis had higher rates of coronary artery disease, CHF, and beta blocker usage. In the carotid endarterectomy group, patients with severe stenosis had lower rates of TIA, 0.7% compared to 1%. Combined TIA stroke at 1.9 versus 2.3%, and both the composite secondary endpoints of stroke death, 1.9 versus 2.3%, and stroke death MI, 2.6 versus 3.2%, as you can see highlighted in the red boxes here. Notably, there were no differences between ipsilateral, contralateral, and vertebrobasilar neurologic events between the two cohorts. Of those who had contralateral neurologic events, roughly 70% of these patients had a greater than or equal to 70% contralateral stenosis. Similarly, in the TCAR group, patients with severe stenosis had a lower rate of stroke TI, 3 versus 4.3%, again highlighted in the red box, with all other differences in outcomes not being statistically significant. And again, the majority of patients with a contralateral neurologic event had contralateral stenosis of greater than or equal to 70%. No statistically significant differences were seen in the outcomes for the transfemoral carotid artery stenting group, as you can see here. On multivariate analysis, coronary artery disease was associated with an increased rate of perioperative neurologic events in the carotid endarterectomy group with an odds ratio of 1.37. Severe stenosis and white race were associated with reduced rates of perioperative neurologic events with an odds ratio of 0.75 and 0.69 respectively. Similarly, in the TCAR group, severe stenosis was found to be protective for perioperative neurologic events, as was P2Y12 inhibitor use with an odds ratio of 0.83 and 0.88 respectively. In the transfemoral stenting group, hypertension and older age were found to be associated with increased perioperative neurologic events with odds ratios of 2.13 and 1.21 respectively. The degree of stenosis did not have a statistically significant effect on perioperative outcomes. In summary, severity of stenosis was associated with decreased rates of perioperative neurologic events in symptomatic patients undergoing carotid endarterectomy and TCAR, but not transfemoral stenting. These events also were the primary drivers for the lower rates of the composite stroke death and stroke death MI endpoints seen in the carotid endarterectomy group. The differences in outcomes seen between the severity cohorts as well as between the endarterectomy and stenting groups suggest that various mechanisms related both to surgical technique and stenosis severity play distinct roles which influence perioperative outcomes. Specifically, the authors cited the possibility that those patients with severe stenosis may have improved collateralization, which limit the clinical insult from embolic phenomena and allow improved tolerance of flow interruptions that are seen in carotid endarterectomy and TCAR. Previous studies have evaluated intracranial collateralization and found worse outcomes in patients with poor leptomeningeal collaterals, as well as an incomplete circle of Willis, suggesting that collateral perfusion does indeed play an important role in perioperative neurologic events. Additionally, the authors suggested that plaque in symptomatic patients with less severe stenosis are likely more unstable and susceptible to embolization during manipulation and carotid revascularization procedure. Limitations mentioned within the paper include the utilization of duplex ultrasonography criteria to identify the patient cohort, which potentially limited the inclusion of all symptomatic patients. The lack of a standardized method of grading stenosis severity across institutions and the potential over-inclusion of patients in the carotid endarterectomy cohort who had ipsilateral ocular or cortical symptoms that were not necessarily attributable to carotid disease. The authors also make note that it was unclear as to whether patients had been evaluated by a neurologic or stroke service in regards to preoperative symptoms and perioperative events, which could have potentially led to the inclusion of asymptomatic patients who are known to have better outcomes. The authors then concluded that the severity of stenosis influenced the rates of perioperative neurologic events in symptomatic patients undergoing carotid endarterectomy and TCAR, but not for transfemoral carotid artery stenting. I'm happy to open the floor to discussion. Thank you for your attention today.
Thank you, Dr. Dargan. Very succinct, but detailed at the same time discussion of this interesting paper. We have a couple of questions in the chat box, but before we start, I kind of wanted to pose a couple of questions to the authors. I found it very fascinating. And I think while this was kind of touched upon, perhaps we could delve into a little bit more depth. You know, we're getting a little bit more sophisticated with duplex ultrasound. And while we've been, as a community, talking a lot about plaque morphology, it seems that it really has not kind of delved its way into the preoperative sort of assessment, if you will, and we don't really routinely make decisions. Perhaps we should. And I just kind of wanted to kind of pose that open-ended question: is that, you know, are we seeing essentially patients who have gone on to become severe and then become symptomatic? Do they have some sort of protective shell, perhaps a calcific shell that's preventing secondary ulceration? Are we seeing a situation where folks with more atheromatous, less calcific debris tend to be a little bit more unstable and therefore more complicated, if you will, at the time of intervention? And then the second part of my question for the authors would be, to what do they attribute the differences between TCAR and transfemoral stenting? In other words, you know, should we attribute all the observations to the flow reversal mechanism that we're seeing with TCAR? And so why is it that with transfemoral stenting, we're not seeing the similar differences between symptomatic severity? I know that was a long-winded question, but I'm happy to open that up to anyone who wants to answer.
I think I can start and just give a little bit about our thought process in writing this paper. It's always been a very significant interest to me. We take it for granted that symptomatic patients who are undergoing carotid interventions have a higher perioperative stroke rate or higher perioperative neurologic event rate. And we take that for granted. That is reflected in all our guidelines, which allow us a higher complication rate in the symptomatic patient. And it's always been very interesting to me to try to figure out why that should be so. We also know that most strokes after carotid endarterectomy, at least, are related to some sort of technical imperfection at the endarterectomy site. So if most perioperative strokes are related to technical imperfections, then why should the symptomatic patient have a higher perioperative stroke rate? you're not having more technical errors in the symptomatic population. Presumably you're doing your operation the same way. So this concept has always been of great interest to me. And that's one of the things that led us to undertake trying to tease out some of these factors. I don't have perfect answers to your questions. I think the differences in what we found between TCAR and CEA as opposed to transfemoral stenting would suggest that there's something about the dissection of the carotid artery itself that's leading to this problem. However, I have a little bit of a benefit in that we do nearly all our carotid endarterectomies at my institution awake. So if these strokes were the result of intraoperative embolization during the dissection, we should see that intraoperatively. So I think it's very interesting. There's a lot of hypotheses. Could the patients who have had a previous stroke or even a TIA have a higher susceptibility to show clinical manifestations of a thromboembolic event? I think that's one possibility. The development of collaterals is another possibility. And as far as the use of plaque morphology to choose interventions, I think as Dr. Picone mentioned, this is a very active area for study. I think it's probably more relevant really to the asymptomatic population in whom we would like a way to predict who's going to have a stroke. So I'll stop there. I hope that tried to answer some of the questions.
No, it did. Thank you very much. I'm going to move on to some of the questions that we have. I have Dr. Stephen Gallo who asks or states, very interesting paper. Do you think we should push the indication for intervention in the symptomatic carotid stenosis patient to greater than 70%? Should we continue treating symptomatic patients with greater than 50% stenosis, or should we do a trial comparing best medical therapy in the symptomatic 50 to 69% with CEA or TCAR?
I mean, my personal opinion is I don't think that we should restrict the indications. I think in a clearly symptomatic patient, even a 50% stenosis is appropriate for indication. And one might argue again that if these are the more unstable plaques, these would be the patients who would be more likely to have another event with medical management as well. A trial is always a nice thing to propose, but I think we have there's enough challenges doing carotid trials these days that I'm not sure that this warrants a specific one, in my opinion.
No, I agree. I think it's supporting to sort of an aggressive approach to the symptomatic patients, especially with suggestive imaging features. Dr. Dubois states, does your paper include near occlusions greater than 95%? It's a very good question. And if so, what is the proportion? And do you think that that group would have lower stroke rates as they would theoretically have been more robust collaterals? And I think this is a particularly good question, especially now that we're seeing this so-called string signs and we're getting a little bit more aggressive, both with CEA, I would say, and TCAR and treating these. So I'm curious what your answer to this will be.
It is a very good question, and I don't happen to have that information at hand. I mean, obviously, the way we analyze data is limited by what we have in the VQI, and I cannot recall over the top of my head whether VQI stratifies the degree of stenosis that specifically. So I don't know the answer to that question, but I think it's an interesting point.
Dr. Rockman, have you found your practice or anyone at your institution, have they become more aggressive about treating these so-called string signs that used to be abandoned before, but now with TCAR and more sophisticated, like awake anesthesia carotid, do you find yourself more aggressive about treating these?
My personal experience is that a lot of things that people call a string sign aren't really a string sign the way I was taught about string signs, with a really, diminutive string-like, for lack of a better term, carotid that goes all the way up to the brain, that may be a post-thrombotic kind of situation. A lot of things that I see that people are calling string signs are really just a diminutive ICA that's not filled well, it's not perfused well because of a very, very severe stenosis, and therefore that artery looks diffusely smaller than the other side. I think I would differentiate between those two. If I think an artery is just underperfused, I just treat it with the same indications. If I really think there's a significant string sign reflecting perhaps near intracranial occlusion, then I'm a little bit more conservative with that patient, but I wouldn't hesitate to explore it in a very symptomatic patient.
Great, thank you. I think we have a couple of comments here. Dr. DeMuzio states our radiologists at Jefferson are working on methodology to determine increased intraplaque pressure that might predispose to rupture, maybe more independent of diameter reduction, more to come. It's interesting. Dr. Dalman states, Tom Hatsukami at University of Washington and many other groups are exploring plaque morphology with MR-based techniques, and others maybe breakthroughs in this area in the near future. And he goes on to state that could be more technical errors in the symptomatic carotid patients if careful dissection techniques were not followed, more important than in non-symptomatic patients, in his opinion.
I mean, I certainly think that's absolutely true. You have to be especially careful with your dissection in a symptomatic patient that has already embolized. And I can't, again, I can't discern this from VQI data, but from my own experience from doing most of my carotids awake, again, we would then, that's something you recognize intraoperatively with an awake patient. And I don't feel like I see that a lot. I don't think that's a very prominent cause of any perioperative stroke in my experience.
Yeah,
Ron,
I mean,
did you want to expand on your comment? Do you want to, I know you had a kind of a little bit there in the chat, but did you want to expand on it a little bit?
I'm sorry, Mr. Who are you talking to?
To you.
Which comment exactly?
No, just, talking about the plaque morphology. You kind of put that in there, and I thought maybe you might have some other
Well, no,
thoughts
that
you
is
wanted
just
to
that
explore with her.
I think most of the faculty on the call know that there's several individuals and different research groups. I mean, going all the way back to even the beginning of the development of the University of Washington criteria, it was understood that stenosis per se doesn't really predict risk, although it does correlate somewhat. Obviously, it's all about what's going on in the plaque. And so I think that's an area that should be, fruitful, field for further investigation, and is. And Tom, I don't know how many people know him, but he's devoted his entire career at this point to trying to come up with MR specific prediction criteria to replace stenosis only. So I would be surprised if we don't see significant advances in this area in the near future.
Well, nice.
Great.
I think that's a great way for us to end this particular section. Thank you very much, Dr. Nassiri, for moderating that section, Dr. Rockman for answering the questions, and then, of course, our presenters from the University of South Florida. We're now going to move to the second group, which Dr. Latz will start us off with that. Chris, you have to unmute yourself.
Sorry about that. The obligatory technical gaffe here. So I'm Dr. Latz. I'll be the faculty presenter here, and then we'll be followed by Dr. Ambrose, who is our first year fellow, who will present the paper. We're presenting impact of an emergency endovascular aneurysm repair protocol on a 30-day ruptured abdominal aortic aneurysm mortality. We'll also be joined by Dr. Dubois, who will help moderate, and then we have Drs. Jones and Moore here, who are the first and senior author of the paper. So we now have about a 2% prevalence of abdominal aortic aneurysm in males greater than 65 years old. Previously, the prevalence was estimated to be 4 to 8%. The decrease in prevalence is thought to be attributable to a decrease in prevalence of tobacco use. There is an increased risk of ruptures, aneurysms enlarge, and there is a significant increase when they increase past 5.5 centimeters. And repair is offered traditionally at 5.5 centimeters in men, and more recently we've trended toward a threshold of 5 centimeters in women. We, of course, operate on symptomatic and ruptured aneurysms and those that exhibit rapid growth, which is defined as greater than 0.5 centimeters in a 6-month period. We also treat aneurysms in concert with other pathologies such as iliac aneurysms. The incidence of ruptured AAAs has been falling in the Western Hemisphere, and this is thought to be attributable to increased surveillance and earlier intervention. The incidence of rupture in the United States is thought to be about 7.3 per 100,000, and about 4 to 5% of so-called sudden deaths are thought to be caused by ruptured abdominal aortic aneurysms. Around 50% of those die prior to reaching a hospital setting. When we think about the pathophysiology of ruptured abdominal aortic aneurysms, we start with a simplified model using the law of Laplace, which basically states that the wall tension is directly proportional to the pressure times the radius and indirectly proportional to the wall thickness. It's, of course, a little bit more complicated by that. Here we have an example of a wall tension map below, and we have to consider things such as aneurysm position, the overall architecture of the aneurysm, as well as intraluminal thrombus. Rupture occurs when the force per unit area within the vessel exceeds the tensile wall strength. Histopathologically, we see in abdominal aortic aneurysms fragmentation of the internal elastic membrane, decreased collagen, and decreased elastin rather, and increased collagen, loss of muscular cells in the medial layer, and increased microvascular infiltration with T-cell mediated inflammation in the median adventitial layers. In terms of treatment for ruptured AAAs, we can see that treatment using EVAR has increased recently, while treatment using traditional open repair has decreased over the years. EVAR has demonstrated a significant reduction in 30-day mortality when performed for elective AAAs, and multiple observation retrospective as well as prospective studies and those that have utilized national or international registries have demonstrated a benefit of EVAR for ruptured AAAs. Famous example is the Albany group with a large single center series in which they've demonstrated a significant decrease in their mortality in their EVAR cohort compared to their open repair cohort with an odds ratio of 2.5 in favor of EVAR. They also were able to demonstrate improved 5-year survival at 37% versus 26% in their single center series. This is an example of their EVAR protocol. We've not been as successful when looking at randomized controlled trials for ruptured AAA. We've been unable to demonstrate any early mortality benefit of EVAR over open repair. Some classic examples are the AJAX trial performed in the Netherlands, the ECAR in France, and the IMPROVE trial, which had centers in the UK and Canada. All of these trials have been heavily criticized. They're plagued by certain methodologic problems, such as small sample sizes and selection bias. And there are admittedly inherent difficulties in studying ruptured AAA in a prospective randomized fashion, which begs the question, is this really actually the best way to answer this question? There's a 2020 meta-analysis performed by Contopotis et al., which included 136 total studies with about 270,000 patients. The EVAR group demonstrated a significant mortality benefit of 24.5% versus 37.8%. And with that, I will turn it over to Dr. Ambrose.
Good evening, everyone. First, I'd like to say thank you to the Journal of Vascular Surgery and the editorial board for allowing me the privilege to present this paper. Our paper this evening is titled Impact of an Emergency Endovascular Aneurysm Repair Protocol on 30-Day Ruptured Abdominal Aortic Aneurysm Mortality, which is brought to us by the Canadian Society for Vascular Surgery from a group out of Calgary, Alberta, Canada. Objective of the paper was to characterize the long-standing impact of an emergency endovascular aneurysm repair, or EVAR, protocol for ruptured abdominal aortic aneurysms on 30-day mortality. The study design, data using strict inclusion and exclusion criteria was reviewed for all patients who underwent repair of an infrarenal ruptured abdominal aortic aneurysm during a 17-year period from March of 2001 to the end of December of 2018 at a regional tertiary referral center, the Peter Lougheed Medical Center in Calgary. The data set was a combination of prospectively obtained data from March of 2001 to February of 2006, in addition to a retrospective review from the remaining time period, March of 2006 to December of 2018. Primary outcome for the paper was a 30-day all-cause mortality with secondary outcomes targeted at overall hospital length of stay, ICU stay, as well as secondary interventions performed during the stay. Statistical analysis of the data included the use of a cumulative sum analysis, which is a validated sensitive means to detect shifts in surgical performance through a period of time. In this case, the Q sum was derived using a regression formula, utilizing a multitude of physiologic factors such as systolic blood pressure, age, and preoperative renal function to predict a 30-day mortality. Additionally, t-tests and Wilcoxon studies were used to analyze their respective data sets. So briefly, this is a portion of the inclusion and exclusion criteria that the institution utilized throughout their protocol to determine a patient's candidacy. Using this inclusion and exclusion model, there was a total of 758 patients identified for review. However, ultimately 376 patients were included as a result or into this study analysis. Briefly, this is once screened into the rupture arm, another set of anatomic criteria as listed above was used to determine an individual's EVAR eligibility. Now we'll move on to some demographics and trends. Table 1 on the left of the screen is a comparison of a variety of preoperative characteristics used during cohort analysis. Of note, the stars on the screen highlight statistically significant differences amongst the pre and post protocol implementation. One should note that not only were presenting blood pressures lower in the post-protocol arm, but there was also a higher percentage of those presenting with systolic blood pressure reading less than 80 millimeters of mercury. Additionally, the post-protocol arm had a lower presenting GFR, as well as a higher utilization of EVAR as means of fixation. On the right of the screen, figure 1 shows us both the annual incidence of ruptured AAAs at this institution as annotated by the black line, as well as the percentage of ruptured AAAs treated by EVAR as annotated by the bar graph. Over the study period, the percentages of ruptures treated with EVAR steadily increases, mirroring the introductory timeframe and accompanying availability of the EVAR technology. Additionally, the overall treated ruptures declined over this period in time. Move on to some of the results of the paper. The top graph is a summary of 30-day mortality rates seen throughout the study period, both risk-adjusted mortality as listed in the top portion and risk-adjusted based on the presenting blood pressures, which is the bottom portion of the top graph. Overall, mortality through the period, study period was 27.1% all comers. Unadjusted, there was no difference in 30-day mortality with pre-protocol mortality of 29.3% versus 26.6% mortality post-protocol implementation. Statistical analysis of the data shows us that there was no risk-adjusted mortality difference between the pre and post-emergency EVAR protocols. That being said, on subgroup analysis, there was a statistical difference in the mortality of those unstable patients presenting with a systolic blood pressure of less than 80 millimeters of mercury with the pre-protocol mortality of 62.4% and a 38% post-protocol mortality. Interestingly enough, when looking at the secondary outcomes as depicted in the below graph, there was a notable increase in hospital length of stay, ICU stay, and the number of secondary interventions performed by the EVAR group post-protocol implementation as compared with the pre-protocol group, but this comparison had not reached statistical significance. Given the increase in illness severity and the physiologic derangement, one must wonder that how this contributed to the lack of difference between the two arms. Apologies for the technical issues. There's another slide that talks about the cumulative sum of the paper. And for those that are unfamiliar with the cumulative sum score, as mentioned at the beginning of the discussion, one of the other metrics analyzed throughout the study period was the cumulative sum. This analysis accounts for various patient characteristics measured preoperatively, which are then used to assess surgical performance and survival as compared to the preoperative mortality estimates. As we look at the graph, one should note that the stable surgical performance with the emergency EVAR protocol introduction, particularly with the late-term improvement over the time period. So in summary, this was a single center's experience utilizing an EVAR protocol for ruptured AAAs to study the potential differences in 30-day mortality pre and post protocol at this institution. Upon completion of this study, it has become one of the largest data sets in the literature to include nearly 400 people over a 17-year period, and shows an improvement in 30-day mortality in physiologically unstable patients and how this particular group should be prioritized to an EVAR first intervention basis. Post-protocol implementation patients were sicker than pre-protocol patients, as mentioned, with a significant portion presenting with hypotension as well as markedly worsened renal dysfunction. Furthermore, through the 17-year period, there was a notable decline in the number of ruptured AAAs presenting to the hospital, with a concomitant increase in the utilization of the EVAR technology to treat these ruptures. While overall mortality differences were not statistically significant between the pre and post protocol, when risk adjusted, there was in fact a statistically significant improvement in survival between those that present with one of the predefined physiologic insults. And lastly, our Q-sum score shows a procedural improvement in the outcomes throughout the life of the study. Next, I'd like to open it up to any discussions, and I apologize for the technical issues.
Great. Thank you for that. Well presented. I just want to congratulate Dr. Jones and Dr. Moore. It's nice to see a Canadian paper being highlighted here. You know, this is a topic near and dear to me. I was Tom Forbes's fellow when we were doing the IMPROVE trial, and I personally randomized 16 patients into the trial. And you had a comment in your introduction about the challenges of randomizing these patients. And all I can say from personal experience that was an understatement. But I think while people are putting in their comments in the chat, maybe I'll start with a question. My question has to do with door to intervention time. So the SVS guidelines recommend a 90-minute door to intervention time, but there's minimal evidence to support that. You know, you found that you were able with your protocol to treat a higher proportion of hypotensive patients. And not only that, they had better results. And that kind of suggests to me that you might have been getting patients to the OR quicker. But I'm wondering if you had any data on that and if you thought that played a role.
Thanks.
We didn't.
Go
Oh,
ahead,
sorry. I can. Well, I'll take it, and then if you have anything to add, we didn't specifically collect that data in particular. And one of the things that makes Calgary unique as a center is that we're the only effectively quaternary care center in Southern Alberta. So we service 3 million people from, you know, hours away by flight in Eastern British Columbia and Western Saskatchewan. So to some degree, the patients that we are seeing have a potentially a survival bias if they're coming from a far distance. And in addition, these patients aren't going anywhere else. It would be really interesting to look at the time to presentation, but unfortunately we didn't collect that data.
Okay, I don't know, Dr. Moore, if you have a sense just that maybe you are getting them to the OR quicker or getting a balloon in quicker, you're getting slicker. Like I remember in your original paper from 2007, you mentioned you were doing groin cut downs and stuff. I'm assuming that's all done percutaneously now. So yeah. I'm just wondering if you had a comment on that.
Sure, Luke. I mean, when I first started out with this protocol in the very early days, I was perpetually frustrated when I was looking at the literature because ruptures were being categorized when clearly some of these were completely rock solid stable. And we were quite heavily criticized for suggesting that we should use endovascular surgery for the sickest of the sick patients. But it made more sense to me in terms of getting bang for the buck that these are the patients that are going to benefit the most by doing the most minimally invasive strategy. So that's where we started. And really this just represents an extension of that protocol over 17 years. With the advances in technology and you know, the perpetual sort of increase in volume, our center does between 150 and 250 elective aneurysm repairs per year. So our team is very, very, very slick at getting these cases done in a hurry. We know all of them percutaneously. And like Dr. Jones said, many of these patients have been physiologically self-selected, which is why we elected to exclude stable contained ruptures. These patients had to present with blood outside the aortic wall. We wanted to make sure we were capturing true ruptures to see if our personal observations could be confirmed statistically. And that observation was that the sickest patients are the ones that have the most to gain.
Great, thank you. So I see we have a comment in the chat. I'll just read that out. It's Dr. Anil Hingorani. Could some of these differences be due to changes in technology over time course of the study, or more familiarity with the surgeons with the techniques? I guess you kind of already answered part two, but I was wondering about that myself, because when I was looking at your data for the later years, there's a couple of years where like 90% of your ruptures were treated endo, or close to 90%, which is great. And I know you guys have access to all the graphs. And are you using like, for example, you have a really angulated neck, you're going to use the Gore graph that you can reposition. And what about things like endo anchors? Like, have you guys evolved to use those adjuncts, and how often is that being done, do you think?
Yeah, so Luke, we have access to all of the sort of known devices. And one of the key things for our center, because we're a relatively high volume single center, is we have everything on consignment. So we have a full tool kit of virtually every single device you could imagine, including Oscar catheters for complex cannulations, Helifix anchors, proximal extension cuffs. And so we're not limited in any way by the technology. I would argue that in our center, and I haven't looked at the most recent numbers since the endpoint in this particular paper, but we continue to hover around 90% for our ruptures. And in fact, one of the things we discovered in the early stages of our first paper was, prior to introduction of the actual stent portion of this, we adopted a wire first protocol, which really just entailed balloon control of the aorta, much like the Reboa series in the trauma literature. And so that step alone was able to significantly impact survival. And we're going to actually look at that as a sub-study of this cohort, just to sort of firm that statistical data. But that strategy alone, wire first with a balloon, can make a huge difference in survival rate.
Yeah, no, I mean, I suspect that's part of why you had such a benefit in the hypotensive patients, is you guys were able to get the balloon up much quicker. I don't see any other questions on the chat, but I guess, another question I had was the patients that are treated non-operatively, because you excluded 19 patients that were treated non-operatively overall. Do you think and I'm assuming, those patients were palliated for various reasons. Do you find that you're able to offer this to more patients with your protocol because you're getting to them sooner, and you're able to treat challenging anatomies? Do you think that played a role? And have you looked at like the number of patients, the proportion that was treated non-operatively over the two time courses, and whether that was different?
Well, I and Melissa discussed that at length, Dr. Jones, and we, the bottom line is we didn't tease that specific element out, Luke, but our personal belief and the data does seem to suggest this, that the patients that we're now operating on are much sicker, and that has to do with the fact that we're more comfortable with the technology and the techniques and the protocol, and the technology that's available to treat these patients. Now that is a double-edged sword, and you can see that because we fully expected, when we embarked on this long-term review, we fully expected that the initial results that we'd encountered in the first trial would have held true, and that all-comer mortality would have been improved. And the reason that we didn't see that, we believe, is that we're now expanding this to that virtually any patient with a rupture that comes in now is being offered at least an attempt at endovascular reconstruction.
Yeah, I mean, I think if you're able to reliably capture everyone who showed up, and including the ones that didn't have surgery, and obviously they all die, I think you probably would demonstrate that, because you're right. I suspect you are treating more of those moribund patients, which is great. I just see a couple more comments that I'll read. Dr. DiMuzio, Randy, I applaud your aggressive approach to endo. Do you anticipate a time when emergent open will not be considered? That's controversial.
We've adopted a very aggressive, it sort of spills over from the trauma literature, that concept of damage control. Yeah. So, we have patients that come in with, ruptures that have necks that are, 5 millimeters or less. And of course, we know that those patients from an elective perspective would be either turned down, or we'd offer them a fenestrated endovascular reconstruction. But if you can get that patient sealed temporarily and allow them to be metabolically stabilized, you can come back and do all kinds of things. Now that we've got HeliFix, proximal Pall-Maz stenting, or even proximal fenestrated cuffs, you can get these patients out of trouble. So I think that the era of slashing into a hypotensive patient's abdomen that is grossly distended with a hemoperitoneum, I think those days probably should be over. That may be controversial to some, but when you get used to putting a balloon up in these patients and then you open the abdomen and everything's quiet and calm, and I think back to my early days when, you're rushing in, you've got a massive hematoma, you're trying to figure out where the anatomy is, and in the middle of all that, the patient's coding. It doesn't take long for you to recognize that there's some benefits to the endo first approach.
Yeah, no, I would agree. I mean, particularly since you can get your balloon in there before they have any kind of anesthesia. And that, as you guys know, that's when they tend to really tank or arrest. I guess my other question would be, like, have you gone even the step further and treated juxtarenals endovascularly with CHEVAR or with in situ fenestration? I don't know if you have any comments on that, but I know we've started doing a bit of that as well. I agree. Like, I'm not the same philosophy. If I can get a seal, the worst thing you can do, though, and I know you know this, is not get a seal. Like if you don't get an immediate seal, like I remember the IMPROVE trial, all the patients that had on-table conversion, they died, and that's like a bad scene. But I agree with you if you can get a seal. But I wonder, what about the juxtarenals? Are you guys expanding it even further, or?
Yeah, so we have not aggressively gone after that cohort yet. I think that we're all of us on this call are anxiously awaiting the development and the opportunity to access the off-the-shelf fenestrated devices. We have not embraced in situ fenestration. We just feel strongly that without the technical limitations that are imposed by regulatory bodies, that doing in situ fenestration really is a bit of a Hail Mary strategy. And frankly, these patients, it takes us a bit long to do that sort of stuff when we try to do that with our thoracic cases. So we haven't extended that, but we have done a couple of cases with parallel grafts technology. So you have in the arm, but for the most part, we're confining this to immediately perirenal or infrarenal aortic aneurysms.
And do you guys use the Ovation for some of these cases too, or just because I don't think I've ever put one in for a rupture, but I'm just curious.
Yeah, so we have a couple of practitioners in our group that are heavy Ovation users. Okay. That being, we've had a couple of near deaths from anaphylaxis as a result of rupture of the rings and exposure to the polymer. And we also did a short series of pullback pressures through the dual rings. And there's a typical gradient of around 40 millimeters of mercury, which may not be much in a healthy patient, but if they've got concomitant peripheral vascular disease, that's a pretty significant inflow obstruction. So we've sort of gotten away from Ovation with the exception of those patients with very small access vessels. As the newer, lower profile devices like GORE become readily available, that advantage will probably disappear, and we'll probably move a bit away from the device.
Yeah, I mean, it's interesting. I mean, your experience with Ovation mirrors mine. I'm not, I agree with, I echo those comments. And I don't know if you ever tried to take one out, explant one, but that they have like this metal cage and it's got like, it's interesting anyway. Not sure if I'm sorry if I missed any questions. Oh, I think Dr. Hingorani had another question. During this study, did the mortality for open repair change? That's an interesting one, because if you're doing more of the EVAR, you're leaving the more complex ones for open. I'm wondering if you have any comments about that.
Yeah, I can take one, Dr. Moore. So we did actually see a trend towards significance in the improvement in 30-day mortality for patients that received open repair after the introduction of protocol. And so I wonder if there's a selection there as well, where as our team became more comfortable dealing with unstable hypotensive patients with an endovascular strategy, the patients that are actually making it to an appropriate open repair are those more physiological robust patients. But Dr. Moore, I'm not sure if you have anything to add there.
Yeah, no, I was going to say exactly the same thing, Melissa, that we actually saw an improvement in outcomes. And I think that probably is because we were literally stenting everybody, including the sickest patients, leaving the ones that were sort of better off to undergo open repair.
Well, thank you. I think that was just an amazing discussion both with Dr. Rockman and with Dr. Moore and our moderators, really delving into this. Thank you so much, Luke and Naeem. I'm really excited. I love when we get into kind of the nuances of the studies and we talk about some of this, because I think it really brings to light the things that we're all struggling with. It is just before the top of the hour, so we will give everybody 3 minutes of their time back. We want to thank all of our speakers, all of our moderators, our author guests that were here. Look forward to seeing you in October 12th. 7 p.m. Eastern time. We will be back with the October version of the JVS Online Journal Club. And thank you and have a good night.
Right. Take care. Thanks very much.
Thank you all. Thank you, Misty.
Have a good night.
Ciao.